Coordinator for Metrolina Trauma Advisory Committee. Welcome to our monthly MTAC Trauma Conference. Please be sure to mute your mics. We typically hold this conference on the third Tuesday of each month on various topics related to trauma, so we hope you join us again in the future. Our next conference will be on November 17th, and the topic is pediatric orthopedic trauma. Be sure to check out our website, metrolinatrauma.org, for more information, or follow us on social media, Twitter, Facebook, Instagram, and LinkedIn at Metrolina Trauma. Our topic today is geriatric falls and evaluation. We're fortunate to have Dr. Justin Kauk from Novant Health with us today to speak on the topic. Dr. Kauk completed his orthopedic residency at UNC Chapel Hill and his trauma fellowship at Reno Orthopedic Clinic and Renown Regional Medical Center in Reno. Dr. Kauk also spent more time out west, but now serves as the medical director of the orthopedic trauma service at Presbyterian Hospital. He has multiple publications and presentations on various orthopedic trauma topics, so he's very well qualified on this subject. And with that, thank you, Dr. Kauk, and I'll turn it over to you.
Thank you, Scott, for your introduction. Is my presentation still visible?
Yes, I can see your title screen.
Okay. I am not seeing it, so let me see. Let me try and share it again. I apologize. There we go. Is it there?
Yes, back to your title screen again.
Okay. Well, thank you all for attending today. Appreciate it, especially virtually. Thank you, Scott, for that nice introduction. So we're going to talk today about geriatric falls, as well as get a little bit into the trauma evaluation of a geriatric patient, as the two are kind of tied together. I have a few disclosures, specifically that I'm an orthopedic trauma surgeon and that I supervise the fragility fracture service. So these are injuries that I see on a daily basis and take care of both operatively and non-operatively. And certainly as our population becomes older, we're seeing with a lot more frequency. So I have a few objectives for our talk today. We're not talking about the season fall, although it is fall, but why should we care about falls? Who falls? What happens when people fall? What are at least 3 risk factors for falls? Can they be prevented? What about anticoagulation in these types of patients? And how should these patients be evaluated in the emergency room? I will warn you, my daughter says I'm the king of dad jokes, so there may be a few in here during the talk. So probably good that this is virtual. So why are falls important? They are the leading cause of injury, both fatal and non-fatal, among older adults in the United States. The complications from falls are the leading cause of death from injury of men and women older than age 65. And alone, they're the 5th leading cause of death in older adults. Both men and women are at risk for falls, so it touches both genders, and female more so than men are at risk. There are many different causes, and there's some data out there that says a single intervention to prevent falls could actually avert anywhere between $94 and $442 million in direct costs annually. So as far as kind of some of the details around falls themselves, most occur from a standing position on a level surface in elderly patients. A lot of times, or infrequently, we see somebody out of an attic or off a ladder, but most of the time these are patients that are lower demand and less active, and so it's usually from a standing height. Typically, orthopedic injury is the most significant complication. Usually, or common injuries include hip fracture or other long bone fracture, pelvic fracture. Outside of the skeleton, closed head injury, or when you get a little more towards the axial skeleton, C-spine and thoracic injuries also occur. The leading cause of injury, as we talked about, is falls. And so almost 30% of adults greater than age 64 reported at least fall in the last 12 months. That's over 35 million falls. 34% of these falls occur in patients who are over age 84. There are 10.2% fall-related injuries that occur, which is 8.4 million fall-related injuries. 50% of falls occur in long-term care settings. And so again, it kind of speaks to which patients are having these. And 60% of people who have fallen in the last year will have a second fall again this year. What are the types of injuries that we see in one study of women under age 70 over a 2-year period? Most of the injuries were minor, about 41%. These just included, bruises and cuts and sprains. The major injuries were about 6%, which can include fracture, dislocation, closed head injury, major lacerations, or even death. In nursing home residents, the major injuries are higher, and we see a rate of anywhere from 10 to almost 1/3 of patients. So what can lead to hospital trips in terms of falls? About 60% of ER visits for patients over 65 are related to falls. 5% of hospitalizations in the United States are related to falls. There's data in the Netherlands that show that their rate of hospitalizations doubled over from 1981 to 2008. We also see that there's about a 15% readmission rate. These are more common in patients who are discharged home or in those who have cognitive impairment. So it's definitely related mortality and morbidity associated with the falls. 95% of all hip fractures are fall related, and that the risk of nursing home admission increases with the number of severity of falls. So people are less likely to live independently the more they fall. Specifically because hip fractures are such a high number related to falls and something we treat pretty commonly, I thought I'd get into a little bit of the data around mortality and life changes associated with these hip fractures. In patients who we treat surgically with a hip fracture, there's approximately 1% mortality at 72 hours post-operatively. That mortality rises to about 4% during the hospitalization. At 30 days, it's around 10%, and at a year, depending on the data that you look at, ranges between 20 and 40%. The mean life expectancy is around a little over 3 years, so around 3 years, about 1,000 days. In these patients who we treat with hip fractures, about 50% lose a level of function. So if they were ambulating independently before, have become cane dependent. If they're using a cane before, have become more walker dependent. And again, if they're using a walker, about half become more wheelchair dependent. And 40 to 60% of these patients lose the ability to live independently. So these are high numbers and important, especially as you consider prevention with osteoporosis treatment. In the patients who we treat non-operatively, there's about a 30% in-hospital mortality rate. It's about 65% at 30 days, up to 85% at a year, and the mean life expectancy is about 220 days. 50% of patients who fall are unable to get up with help, and so this can lead to delayed presentation. We see that in these patients, about 35% have a lasting decline in their activities of daily living. And again, 40 to 60% lose their ability to live independently. Again, as we kind of talked about, the risk of nursing home admission increases with the number of severity of falls that patients have. And in those who present to the ER, around 2% of falls result in death. In white men, it's about 48.3 per 100,000 people. The falls are expensive, as I kind of quoted you one number already, but in patients over age 65 in 2015, there was a $50 billion cost to falls in US dollars, even though I've got the Zimbabwe $50 billion here, that's in US dollars. So what are the risk factors for falls? They are multifactorial. Things like an acute illness, fever, dehydration, a heart arrhythmia or dysrhythmia or UTI can predispose to falls, be related to medications, environmental causes such as unstable footwear or a wet surface that they're walking on, prior history of falls, any lower extremity weakness that the patient might have, age, female gender, any sort of cognitive impairment, balance issues, specifically psychotropic drug use, arthritis, prior stroke, which may have some hemiparesis related patients with a history of orthostatic hypertension, dizziness, anemia, and actually hearing loss has a almost two times greater odds risk of falls relative to patients with normal hearing. Those risk factors associated for major injuries are patients who had a syncopal episode associated with it, history of a prior fall with injury, or those with decreased executive function. Excuse me, that says infection, it should be function. What are the top causes? So the most consistent are patients with gait and balance issues, with medications being second. And the more risk factors a patient has, the higher the risk of falls. And again, there's a higher risk of falls in patients who are recently hospitalized or with other risk factors. And again, as we talked about, as we get older, higher risk, and as female gender is a higher risk. So specific things that can affect gait and balance might be any sensory issues such as proprioceptive sensitivity loss, changes in the inner ear, or ganglion cells of nerve fibers, loss of neurons and neurotransmitters. So again, patients with peripheral neuropathy, diabetes, any patients with issues with muscle activation or composition. As we get older, we tend to activate our proximal muscles first, and greater contraction of antagonistic muscles. And just again, with age, we see a decline in patients' ability to rapidly develop torque over their joints, and so they're unable to correct when they stumble. Also, visual impairment can lead to falls, and then again, prior history. Systemic blood pressure issues such as hypotension, any vascular disease, or altered cerebral perfusion, altered baroreflexivity, changes related to meals, or just an age-related reduction in total body water. As far as chronic disease, certainly anything that can cause unsteadiness, such as Parkinson's disease or any chronic musculoskeletal pain, diabetes, osteoarthritis, cardiovascular disease, and any sort of cognitive impairment, even mild cognitive impairment. Certainly ingested substances can play a role in falls too, specifically like from a prescription drug standpoint. Neuroleptics, benzodiazepines, antidepressant sedatives all can play a role in degree of alertness and predisposed to falls. Antihypertensive, secondary to low blood pressure, any other cardiovascular medications, and then of course alcohol use. There are also environmental factors. I hear a lot of patients say, I was walking in my house shoes when I fell. So wearing appropriate footwear, or due to the environment that the patient is in, whether it be inside or outside, or if they're walking on slippery grass. Again, we talked about those in skilled nursing have a higher risk of fall. And then patients with vitamin D deficiency actually have a greater risk of fall as well. And so what are other risk factors, and how can we do a risk assessment? So when we talk to patients, we want to find out if they've had a prior history of fall. I know this is something that I'm not the best at, but I think from a primary care standpoint, as well as when patients are seeing the ER and being evaluated, we need to inquire if they've had falls before. What were they doing during the fall? Any sort of symptoms that predispose? Were they lightheaded? When and where did it occur? Did they get up in the middle of the night to use the bathroom and then fell? Those sorts of things. Do they have any history of lower extremity weakness or chronic underlying diseases we discussed before? Any issues with malnutrition that could affect their muscle mass and strength? What medications do they take? And then specifically on the exam, looking at any postural vital signs, any vision or hearing loss, and assessing their extremities, looking at their gait, whether there's any unsteadiness, any stability issues in their posture, and then any foot disorders such as bunions or callus or other things that can affect sensation, any neuropathy, any arthritis, and then hips, knees, or ankles, and then overall strength. And then, when you talk about a diagnostic workup, there's no one test to really evaluate, though in someone who may have some unexplained falls, it may be worth evaluating their carotid sinus sensitivity to determine if that's playing a role. And so what are things that can be done to prevent falls? Well, there's certainly the helium balloon approach, but we know that's probably not realistic. And so a lot of times when we're meeting older patients in the community, we don't always know that they have falls. We don't always screen for them. They don't always immediately divulge it unless you inquire. So we need to assess their risk. Any modifiable factors, decreasing polypharmacy, things like that. And then one of the things that can shown to decrease the risk of falls by up to a quarter is exercise at least 3 hours a week to work on gait and balance, strength, things like movement, for dance or Tai Chi, aerobic exercise, and then a physical therapist or an occupational therapist can work with the patient to help develop a safe program. Let's see. And so, you know, what sort of things can be done to prevent falls? Certainly, any multifactorial interventions show the best results. These include home safety interventions, such as installing handrails, improved lighting, anti-slip surfaces, can actually lead to up to a 25% decline in these injuries. As we touched on the last slide, exercise, assessing any vision issues, optimizing medical comorbidities, optimizing nutrition, and just education of patients. There's no evidence that the following prevent falls, such as hip protectors. So, you know, we can return those bubble wrap pants. Part of that may be secondary to compliance. It's a little hard to evaluate. In the studies that I read, that the compliance was not high in those patients. And there's no actually evidence that assisted devices can prevent falls. I certainly see a lot of patients who need a cane or use a walker, and we prescribe them, but then I see them carrying it, or they say, well, when I'm in the house, I kind of cruise from wall to wall, and so even with prescription of these, they may not always be used. And then looking at medication modification, again, decreasing polypharmacy, specifically looking at any depression medications or any benzodiazepines or depression medications that could be influencing falls, opioid medications, of course. And then this was interesting to me that again, we talked about vitamin D can increase the risk of falls if it's low, but actually there's data that shows that higher levels of vitamin D given at less frequent intervals may actually increase fall risk. So, you know, we tend to think we give patients ergocalciferol if their vitamin D is less than 20, but it may actually be that giving them cholecalciferol instead on a BID basis as opposed to ergocalciferol on a weekly basis may actually be better. And overall, vitamin D improves bone density and muscle function. What are the poor prognostic signs as related to falls? So certainly a patient who's unable to get up by themselves and spending a prolonged time on the floor. Certainly had patients that we've taken care of where it's been at least a day since their fall that they present. And you know, there's just a high risk of dehydration, you know, urinary tract infections, pneumonias, blood clot associated with that, usually associated with more serious injury or other medical issues that keep them from being able to get up on their own, and more of these types of patients move to long-term care. In a group of 110 patients that were over age 90, 66 of those people had 265 falls over a 1-year time period, and 80% of those patients were unable to get up after at least one fall, and they spent a third spent at least an hour on the floor. And we've all seen the commercial. I had the picture from it about the patient who's fallen and they can't get up, and how life alert is important for our elderly to have. In one study that they did, 99% of patients had some sort of call alarm, but 97% of the patients on the floor for greater than 1 hour didn't use it. And so, you know, whether this is an education thing, whether they're not wearing their necklace, or you know, I think, you know, the call alarms and life alert may not always be the solution. Be interesting to see any sort of smartphone application that could develop around this that could kind of measure a patient's postural position, whether they're standing and falling, and how long they're sedentary for. Or I know I've taken care of some patients whose families have installed cameras And so if there's any way to kind of create an alert through like a webcam or something like that to be able to alert family or friends or emergency services if patients have had a fall and they're not able to get up. Certainly a lot of our patients are on anticoagulation, whether it be the novel oral anticoagulants, Coumadin, or even just the antiplatelet agents. But a predisposition to falls, even those who are at higher risk of head trauma, is rarely a contraindication to the use of anticoagulation in older patients with atrial fibrillation. And actually, the risk of subdural hemorrhage is so low that patients with an average risk of stroke from atrial fibrillation must fall approximately 300 times in 1 year for the risk of anticoagulation to outweigh its benefits. You know, it was one study that I found. I certainly, as a surgeon, we deal with our fair share of complications related to anticoagulation, and I've got 2 patients actually I've operated on this week for spontaneous bleeds related to bleeding diathesis and anticoagulation. So, you know, it certainly can cause issues, but at least in the data that's available, it may not. You know, I think it's something we always need to discuss the risks and benefits with our patients, but we maybe not be a knee-jerk reaction to stop it in everybody who has AFib. Switching gears just a little bit and kind of looking at the evaluation of falls and how that might relate to geriatric trauma. So really, geriatric falls are geriatric trauma. As we talked about, most of the falls are from a standing height, and so they aren't necessarily high energy injuries. Geriatric trauma patients have greater comorbidities. They have a higher risk of severe disability and death, and they're more susceptible to injury from low energy mechanisms, again, from a standing height. From a physiologic standpoint, they're less able to compensate metabolically, and then medications that they use, such as beta blockers or other things like that, may blunt their physiologic response to the stress of trauma, leading to more challenge in identifying compromise as well as increased complications. And so again, falls are the most common cause of injury over 65. 3/4 of trauma in this patient population relate to falls. The probability of a patient having to fall at least once per year is about 27% in this age group. And we're seeing an increase in the age-adjusted mortality in these patients. And so this is kind of a summary slide of how geriatric patients respond to trauma and sort of the implications that relate. And certainly you can see it affects the pulmonary, cardiac, renal, hepatic, GI, immune system, musculoskeletal system, and neurologic. And we'll get into this a little bit more on the following slides. So from a compensation standpoint, older patients are able to compensate less, and so they tend to be under triaged because we think that their vital signs are normal when in actuality things may not be as normal. They're less able to compensate for any metabolic disturbance, and they have a normal respiratory rate despite any hypoxia or hypercarbia. Older patients who have a pulse greater than 90 and a systolic less than 110 have an increased mortality rate in this setting of trauma, and that baseline hypertension can alter manifestations of shock. And so it's helpful if you've got any notion of what the patient's normal blood pressure runs, and evaluating their current blood pressure can sometimes clue you in as to whether there's an abnormality. Some authors also recommend that we use a pulse greater than 89 as the threshold for defining tachycardia in this age group. So who should be evaluated in a trauma setting? So trauma patients greater than age 60 to 75 should be evaluated at a trauma center with trauma team activation whenever possible, regardless of the mechanism. So that includes these patients who have a fall from standing. The CDC recommends direct transport of any patient older than 64 with a systolic blood pressure less than 110. One retrospective study shows that there's about a 50% under triage rate in these patients, again, kind of outlining the importance of getting these patients to a trauma center sooner rather than later, and that we see improved outcomes in older patients who have significant injuries when they're taken to level 1 or 2 centers. What are the common injuries that we see again? We touched on these a little bit, but we'll get into a little more detail. Patients with neurologic Complications can be like subdural hematoma. You have an increased risk. The brain shrinks, and so there's more space to blood to accumulate. And because of this, the signs and symptoms of the subdural may actually be more delayed than what we would normally see. They're less able to compensate again for metabolic disturbances, which we discussed. And then they may have underlying dementia or other things that may play a role, and so it may be difficult to appreciate a change in their mentation. Certainly, we all know that medications can play a role. The more medications that we add, increased odds of death occur, including beta blockade and chronic glucocorticoid use. Altered drug metabolism can occur, related to just their age specifically, or polypharmacy, which can complicate management. And as we talked about before, the psychotropics can certainly increase the risk of trauma. And there's data that shows that the addition of even one medication is associated with a significant increase in falls. And so what are the major comorbidities that have the highest mortality risk in fall patients? Sorry, let me pull this back up. Patients who have liver disease, any sort of kidney disease, any malignancy or decompensated heart failure, especially on those patients with anticoagulation, with known anticoagulation, or on those taking beta blockers, are at a higher risk. And so, again, we kind of talked about this briefly, but specifically in the setting of trauma, we want to know immediately what happened prior to the traumatic event, what medications, what comorbidities, and then what was the baseline level of function. Were they a community ambulator? Were they a household ambulator? Did they use any assisted devices? What was their baseline cognitive function? Did they have any hemoptysis from a prior stroke? Those kinds of things. And then does the patient have any advanced directive or healthcare proxy to help determine goals of care, and whether it's something that we need to do full court press, or whether we consider involving palliative care or hospice. And so what kind of pre-hospital care should patients get? Again, we talked about the importance of considering transfer to a trauma center, and that these patients are at high risk for cervical spine injuries, and so probably most of them should be placed in a C-collar. Geriatric trauma patients should get the standard ATLS survey, just as any other patient under 65 would. Specifically, issues that may arise in elderly patients, though, may be related to any airway abnormalities, like they have decreased motion, either through arthritis through the jaw or limited mouth opening. If they don't have dentures that are in, it may make it more difficult to get a good seal for bag masking. We want to consider early administration of high supplemental oxygen. And there was one study when patients, when the respiratory rate dropped below 10 a minute, that there's increased mortality. And then early aggressive airway management, and to consider tracheal intubation is needed. But considering how much medication you're using, and to consider decreasing the dose 30 to 50% in the RSI medications. And also, if needed, consider non-invasive positive pressure ventilation. Still within the primary survey, looking at the circulation, trend vital signs and interpret them based along the patient's baseline. Again, trying to determine if the patient has what their usual heart rate runs and what their typical blood pressure is. Signs of shock may include very subtle alterations in mental status, mild tachypnea, low urine output, and delayed capillary refill. Consider an ultrasound of the chest or the abdomen to evaluate for any occult injury, serolactates, and venous or arterial blood gases. And then aggressive resuscitation. Certainly we try not to overload patients, but bolusing them 500 milliliters and assessing their response and repeating as needed. And if there are signs of hypotension or hypoperfusion, even considering transfusion of blood prior to what you would even consider giving them crystalloid for. Hemorrhage is the most common cause of shock in older trauma patients, and so you want to have a high threshold for development of MI or a pneumothorax. And so looking at the disability of patients, it may be challenging Those who have a significant closed head injury may have no neurodeficits on the initial exam, or again, it may be complicated by any dementia or neuropathy or weakness that they may have had pre-injury. In the emergency room, being aggressive with monitoring and serial exams, looking at vital signs, mental status, and any areas of concern, reassessment of an arm or leg or something like that, and doing so frequently. In a patient, for an example, somebody who's 70, who's otherwise healthy, who has significant trauma, such as would occur in an MVC, you want to consider a focused reassessment every 5 minutes during the primary and secondary survey, every 15 minutes during the first hour, and then every hour thereafter until the patient's either discharged or admitted. Use of a cardiac monitor, use of a pulse oximeter, and measuring the end-tidal CO2, especially in patients who have respiratory comorbidities. Looking for cold injuries on the secondary survey, again, older patients may have decreased pain perception or localization, or there may be other things related to that, such as dementia that can make it difficult to assess. And so you want to continue to assess for altered mental status, trend the vital signs, look at urine output, evaluate any worsening pain that may be evolving, assessing respiratory difficulty, and again, just reassess. And just being thorough, as we would in any other patient, looking at the head, the cervical spine. You evaluate for any burns that may be related, clavicle or rib fractures, hip or pelvic fractures. And it shows that if we consider the addition of age 70 as criteria for trauma team activation, insert early intensive monitoring, that survival and increases and disability decreases in this age group. We want to be appropriately aggressive with pain management, using opioids for significant pain. Fentanyl is a good medication due to its short duration. Hydromorphone has a longer duration, but morphine metabolites can cause respiratory depression, actually increase the seizure threshold in kidney patients or anybody with renal insufficiency. Again, monitoring for any urinary retention, any nausea, any constipation. And those are at high risk for renal insufficiency. Avoid anti-inflammatory non-steroidals. Typical evaluation, any geriatric trauma patient should include a type and cross. Again, evaluating degrees of perfusion and hypoperfusion and resuscitation by following lactates. Repeating every 1 to 2 hours is needed. Anything over than 2.4 should suggest hypoperfusion, and a lactate or a base deficit greater than -6 has a 60% mortality in trauma patients who are older than age 54. Again, looking at arterial and venous blood gases, hemoglobin, hematocrit, BUN, creatinine for kidney function, glucose, BMP, coags, and getting an EKG, and certainly chest x-ray. Image liberally if possible. Again, chest x-ray, CAT scans as needed, ultrasounds, but be wary if the patient does have compromised renal function of contrast nephropathy. Usually the common and the high-risk injuries that we see in these patients, again, which can occur from high-energy trauma or low-energy trauma. Patients who have a head injury and a GCS less than 9 have at least an 80% mortality or major disability. Again, this can be harder to assess in older patients. Most head trauma does occur from falls and can occur from minimal trauma. Usually recommend getting a CT head in almost all patients. And about 10% of patients with head trauma on warfarin, they can still have an intracranial hemorrhage, and up to 15% of these patients is asymptomatic. If someone has an INR greater than 1.6, consider reversal within 2 hours of admission. Certainly in patients who have post-traumatic intracranial hemorrhage on CT scan, any decline in mental status, a new neurodeficit, or in the setting of supertherapeutic INR and a known injury to the head. As we talked about anticoagulation, we want to be aware of other anticoagulants and reversal, Coumadin, the antiplatelet agents. Also inquiring if there are any herbal supplements that they take. And then if needed, in Coumadin patients, giving unmatched FFP judiciously is needed to prevent fluid overload. If patients don't have any initial bleeding, it's okay to observe over a 12-hour period, but would make sure that we're doing that frequently within that time. Cervical spine injuries can occur from seemingly minor mechanisms, and we see typically high cervical or type 2 odontoid fractures. Central cord syndrome is also at a risk secondary to hyperextension. We always want to be wary of chest injuries. Usually rib fractures are the most common. They are associated with increased risk of complications and death, even with less than 4 non-displaced fractures, which can cause pneumonia and pulmonary contusions. For each rib fracture that occurs in patients over 65, mortality rate increases by about 20%. And so even in patients with one hip fracture, admission or observation is recommended. And if they have multiple rib fractures, advanced imaging is recommended. Abdominal trauma, older patients may have a less reliable exam secondary to diminished pain sensation and increased laxity of the abdominal wall. So again, image early, ultrasound, CT scans of the abdomen. Musculoskeletal injuries, as we discussed earlier, are the most common type of injury sustained by geriatric trauma patients. Certainly hip fractures are very common. An MRI is probably the best study to perform to look for an occult fracture if there's something that you can't readily see on radiographs. Pelvic fractures can lead up to a 30% mortality, and as compared to patients under 55, there's a 4 times higher mortality in older patients. Usually the most common type of mechanism is a lateral compression mechanism, and these older patients have an increased risk of major hemorrhage. Again, we recommend early aggressive approach to identify any bleeding that may be happening and to stop the bleeding. So consider general surgery or early orthopedic consultation, angiogram if needed. And if a patient presents with a pelvic fracture and hemorrhage, they recommend that they are aggressively managed. So signs of this might include tachycardia, need for ongoing transfusions, or any hematoma on CAT scan. The goal is for patients not to end up looking like this, and so certainly we also want to look at the wrist, the proximal humerus, clavicle, ankle, vertebral bodies. All those are at higher risk for fragility fracture from low energy as well as certainly higher energy mechanisms. And so again, the indications for transfer to a trauma center in these older patients might include blunt chest trauma, even with one rib fracture or clavicle fracture, any sort of blunt abdominal trauma with any symptoms or findings, head trauma with altered mental status or other injury, and any trauma in the extremities that limits ADLs or pain is uncontrolled or patient has shortness of breath. And I know this is something that we sometimes run into, but the importance of don't delay transfer to perform imaging. Just get the patient to the trauma center, and then the workup can continue. Patients who have trauma in the elderly should be considered for ICU admission if they have a significant injury to one or more organ systems, have 2 or more rib fractures, have a serum lactate greater than or equal to 2.4, or if there's any concerning vital sign trend. So in summary, falls are common in the elderly. Many things can lead to falls, and there are certainly some things that can be used to prevent falls. There's a high morbidity, mortality, and cost to society, and that these patients who have falls should be evaluated as trauma patients. I open it up to any questions that somebody might have.
Excellent, Dr. Kauk. Quick question. What would you say is the most commonly missed thing, whether it's pre-hospital or from a regional referring center, a smaller hospital that's transferring in to the orthopedic hospital?
It's a good question. I think it depends kind of on the other injuries. I mean, I commonly, perform primary survey and then a secondary survey, and even the following day, survey them again and ask if they're hurting anywhere else. In kind of the general trauma patient, we see things like metacarpal fractures and finger fractures and kind of small things that maybe don't necessarily change what our treatment was going to be, or certainly, are urgent to treat surgically. But I'd say it's probably more small things. One thing that may, during initial assessment, may not be as concerning, but I think it's certainly worth noting, is that if somebody has a fall, especially if they're on anticoagulation and they've got swelling, kind of continual reassessment of that arm or leg or whatever is, I think they're at a higher risk for ongoing bleeding and potential development of compartment syndrome, or even not compartment syndrome, a subcutaneous hematoma that could threaten the skin and cause, blistering or skin necrosis that might necessitate skin grafting or something. And so the earlier you can kind of catch those things and intervene and notify the appropriate service to evaluate, I think the better. Because I think, especially, as the older patients, the skin is thin, and if you get skin necrosis, it's challenging if the skin dies. And I think there's just more morbidity with, skin grafting and some of those things, and maybe patients of this age group.
Great, thank you.
I have a question.
Sure.
Dr. Kauk, if you could construct sort of like the world's most perfect rehab for these geriatric fall patients in an attempt to lessen their risk of future fall, what would you consider to be vital, and what types of rehabilitation should we be concentrating on in these patients post-trauma?
Yeah, I think certainly managing the medical issues such that, that doesn't put them at a higher risk of fall. But I think really working on strength and balance. And so I kind of outlined on the one slide, aerobic exercise, things like Tai Chi. And then from a kind of further prevention standpoint, making sure that, like, we do a home safety evaluation to remove any potential sources of future falls. But I really think working around a program where we're addressing kind of overall strength and mobility is the most important. I think from a secondary prevention cause as well as kind of decrease the related morbidity from falls is things like an osteoporosis or fragility fracture program that assesses vitamin D and looking for ways as prevention of future fractures is important, but that's not necessarily in like a rehab setting.
Thank you.
There was a question in the chat box asking, how can we promote or change geriatric traumas being sent to an appropriate trauma center? Current protocols in the area don't differentiate that for EMS agencies.
Well, and I think that may be kind of working together with MEDIC and our trauma centers in the region and sitting down and developing some criteria to say, these are patients that probably really ought to be transferred here as opposed to staying where they are. And, again, it's a little hard. We run into this all the time where sometimes you don't initially find out until you get some more imaging and so we certainly don't want to delay care, but, we at least kind of may need to sit down with our trauma surgeons and ERs in the area and really develop some criteria to help facilitate early transfer.
To add on to that, we have a pretty strong regional network here with our EMS agencies, and with collaboration between the different hospitals and the medical directors at the EMS agencies, and then data from our hospitals. Our registry is really strong and able to provide good data, and we can try to narrow down where any potential misses were and how we can try to correct those. So if you have any concerns, please shoot me an email and we can try to get more information on that.
I just had kind of a short quiz at the end here if there aren't any concerns, sort of reinforcing some of the things we talked about. What is the leading cause of injury in elderly patients? Car accidents, falls, kitchen injuries, golfing accidents. So it'd be falls. Men are at higher risk for fall than women. That's false. What is the 1-year mortality rate of a hip fracture fixed surgically? It's 20 to 40%. And then geriatric fall patients greater than 65 should be transferred to a trauma center with trauma team activation. True or false? As we talked about, true. And so here are those answers. Well, Scott, thank you for the opportunity to present today.
Yes, thank you, Dr. Kauk. That was very good. I learned quite a few things. I hope everybody else did. If there's no other questions, we will end it. And again, thank you, Dr. Kauk.
Thank you all. Have a good afternoon.